Hello and welcome to the topic basal cell carcinoma in the dermatology module. By the end of this topic, you should be able to define basal cell carcinoma, explain the pathophysiology of this condition, outline the causes and classification of basal cell carcinoma, describe the clinical manifestations of basal cell carcinoma, outline the investigations that are done, discuss the principles of management, and discuss the complications as well as the prognosis of basal cell carcinoma. Let's get started. Basal cell carcinoma is a type of skin cancer that emerges from folliculosebaceous apocrine germ, also known as trichoblast, which is found in the lower epidermis. This tumor is slow growing and it infiltrates surrounding tissues. The histomorphology of the cancer resembles basal cells of the epidermis, hence it is known as basal cell carcinoma. Our skin is made out of epidermis and dermis. The epidermis consists of stratified squamous epithelium, which are the keratinocytes in progressive stages of differentiation. Layers of epidermis are stratum corneum, the absorptive layer, stratum lucidum, which is only found in thick skin, stratum granulosum, also known as the granular layer, stratum spinosum, the prickle layer, and germinative cell layer known as the stratum basale. Epidermis functions as a physical and biological barrier to prevent penetration by irritants and allergens. Dermis is the inner layer of the skin and it's much thicker than the epidermis. Its function is to protect and cushion the deeper structures from mechanical injuries, providing nourishment to the epidermis and for wound healing. Overall, the skin is essential for protection as it forms a protective barrier to protect us from mechanical, thermal, and other physical injuries, as well as harmful agents, excessive loss of moisture and protein, and harmful effects of UV radiation. Skin is also needed for thermoregulation by altering blood flow through the cutaneous vascular bed. And lastly, skin is the organ that provides sensation to our bodies. Chronic sun exposure and UV radiation will cause direct DNA damage. Indirect DNA damage is done through production of reactive oxygen species and immune suppression. The mechanism of injury occurs initially with melanocytes absorb UVA, leading to indirect damage to the DNA through free radicals, while UVB causes direct damage to DNA and RNA. UV exposure causes dose-dependent suppression of the cutaneous immune system and thus impairing immune surveillance of skin cancer. Mutation of PTCH1 gene causes Gorlin syndrome, which is a rare inherited disorder that increases risk of basal cell carcinoma during adolescence or early adulthood. Risk factors of basal cell carcinoma are UVA or UVB exposure, ionizing radiation exposure and arsenic exposure, immunosuppression as well. Genetic predisposition increases risk of basal cell carcinoma. It includes history of current xeroderma pigmentosum, basal cell nevus syndrome, Bézek-Dupré-Cristol syndrome, and Rombo syndrome. Basal cell carcinoma are classified based on its histopathological features. Superficial basal cell carcinoma has buds of basaloid cells descending from the epidermis without dermal invasion. Nodular variant of this basal cell carcinoma consists of islands of cells with peripheral elongated cells and arrayed arrangement of the central cells. Sclerosing or morphea-like basal cell carcinoma has spiky basaloid thin strands of cells that invade the dermis and is surrounded by dense fibrous stroma. If there's presence of melanocytes and melanin admixed with tumor cells, it is known as pigmented basal cell carcinoma. Infundibulocystic basal cell carcinoma are found on the face. They are small and well circumscribed. It is composed of nest of cells arranged in an anastomosing manner with little stroma. Basosquamous basal cell carcinoma has features of both basal cell carcinoma and squamous cell carcinoma, which is nested and strands of cells maturing into larger and paler cells. Fibroepithelioma of Pincus has soft nodular lesion resembling a fibroma or papilloma and is frequently found at the lower part of the back. Patients will complain of skin changes such as appearance of shiny pink or flesh-colored papule or nodules. Nodular basal cells are normally found on the face, including nose, cheeks, forehead, nasolabial folds, and eyelids. There might be history of crusting and recurrent bleeding as well. Superficial basal cell carcinoma are found on shoulders, chest, or back and often of multiple lesions. There are also pigmented variants of superficial basal cell carcinoma which are similar to eczema or psoriasis. Morphea-form basal cell carcinomas resemble a scar or plugs of morphea. Upon examination of the lesion, it commonly has surface telangiectasias. It is known as a rodent ulcer when rolled borders and ulceration are present. Superficial basal cell carcinoma are pink and red, scaly with macular patch with telangiectasia. Morphea-form basal cell carcinoma are white or flesh-colored with areas of induration and ill-defined borders, crust with erosions or ulcerations and superimposed papules with telangiectasias. Basal cell carcinoma's pathognomonic signs are pearly elevated patch on the skin, dimpled midpoint and grows slowly, painless but might itch and bleeds, and there will be surface telangiectasia. A complete skin examination should be done to look for signs of basal cell carcinoma. Dermatoscopy shows scattered vascular pattern, telangiectasias, hemorrhage, ulceration, hypopigmented area with blue-green nest, and red dots or globules. Skin biopsy is the gold standard for diagnosis. It can differentiate between superficial and other invasive histological subtypes. Histopathology will show basal cell that form clusters and islands with peripheral palisading nuclei. Medical treatment is reserved for superficial basal cell carcinoma and for poor surgical candidates. When surgery is contraindicated, radiation therapy is used as treatment or as adjuvant therapy. Drugs include topical 5-fluorouracil and imiquimod 5% cream. Surgeries aim to complete removal of the tumor to prevent recurrence, to correct any functional impairment due to tumor, and to give the best cosmetic results to patients, especially their face. Mohs micrographic surgery is the gold standard surgical treatment. Other surgery includes standard surgical excision and cryosurgery, which include application of liquid nitrogen to the clinically visible tumor and a small surrounding margin of normal appearing skin for margin control. Chronic basal cell carcinoma, if left untreated, it will infiltrate to the surrounding structures, causing disfiguring, cosmetic issues, and recurrence. Basal cell carcinoma has the potential of recurrence after initial therapy. Its prognosis is based on the location of the primary lesions. Low-risk locations are trunks and limbs, while forehead, cheeks, chin, neck, and scalp carries intermediate risk. High-risk locations are centrofacial areas, nose, ears, periorificial areas, and embryonic fusion planes. The clinical and histopathological features such as its size, the histological type, primary or recurrent tumors also contribute to the prognosis. Primary superficial basal cell carcinoma and primary nodular basal cell carcinoma of less than 1 cm have better prognosis. Same goes to the intermediate risk location or lesions of less than 2 cm in low risk locations. Intermediate prognostic factors are recurrent superficial basal cell carcinoma and nodular basal cell carcinoma, which are less than 1 cm in high-risk location of less than 2 cm in intermediate risk locations or more than 2 cm in low-risk locations. And finally, nodular basal cell carcinoma of more than 1 cm in high-risk locations have high-risk recurrence. Other poor prognostic factors are morphea-form, infiltrative or histologically aggressive tumors and recurrent tumors. Now let's summarize what we have covered so far. Basal cell carcinoma is a type of skin cancer that emerges from follicular sebaceous apocrine germ, which is known as trichoblast. It can be a result of chronic sun exposure and genetic mutations. Other risk factors include exposure to ionizing radiation, arsenic exposure, and immunosuppression. Basal cell carcinoma appear as flesh or pink-colored, pearly papules with overlying ulceration or telangiectasia vessels, which commonly appear at the head or neck. Basal cell carcinoma diagnosis is based on clinical examination and skin biopsy. Surgery is gold standard and its modalities include excision, cryosurgery, and Mohs micrographic surgery. We have come to the end of this topic. Thank you for your time.